Good afternoon, good evening, everybody. My name is Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. Public health is shaped by the public conversation about health. How we talk about the social, economic, and political conditions that determine our health matters for how we engage with these factors towards building a healthier world. These events are meant as spaces where we can have these conversations. Thank you for joining us for today's discussion. Thank you too to the many who worked to make today's event happen, in particular, our Dean's Office and Marketing and Communications team. We're here today to discuss the effects of war on population health. War harms health in a range of ways in both the near and long term. With the outbreak of war in Ukraine, we have a responsibility in public health to shine a light on these consequences and make the case that a healthier world is one without war. The horrors we have seen in Europe are a stark reminder of these consequences and the urgency to address them. We are joined today by a panel of experts who will guide our conversation about war and population health. Thank you to all our panelists for joining us as we work to define our role in this uncertain historical moment. I'm now very pleased to introduce today's moderator, Tiziana. Tiziana is the host of Radio Boston on WBUR. She has been a commentator and contributor to WBUR for more than a decade and has contributed to a number of other regional and national news outlets. Prior to joining the Radio Boston team, Tiziana was professor at Boston College at the School of Social Work, where she taught social innovation and leadership. A longtime anti-poverty advocate, Tiziana also ran Boston Rising, a startup anti-poverty fund to end generational poverty in Boston, and was the first woman president of Catholic Charities for the Archdiocese of Boston. It's now my pleasure to turn the event over to Tiziana, who will introduce today's speakers. Tiziana, over to you. Thank you.
Dean Galea, thank you so much. I'm delighted and I feel privileged to moderate today's discussion. It's an important topic. It is timely. So I will briefly introduce our presenters and then we'll jump right in. First, we'll hear from Professor Theresa Betancourt. Professor Betancourt is the inaugural Salem Professor in Global Practice at Boston College's School of Social Work, Director of the Research Program on Children and Adversity, and a former colleague. Her primary research interest is to understand the protective processes that contribute to risk and resilience in the mental health and development of children and adolescents who are facing adversity in a variety of cultures and settings. Then we will turn to Dr. Abdulkarim Ekzayez. Dr. Ekzayez is a Syrian medical doctor and an epidemiologist. His work focuses on the public health impacts of conflict, protection of healthcare in conflict, health systems strengthening, and building health research capacity in conflict settings. Thirdly, we will hear from Professor Larissa Fast. Professor Fast is a scholar working at the intersection of the worlds of academia, policy, and practice. Her research addresses two fundamental problems: how best to protect civilians, particularly those who intervene in violent conflict, and how to make such interventions more effective, ethical, and responsive to local needs and circumstances. Finally, we will hear from Dr. Amir Khorram-Manesh. Dr. Khorram-Manesh is with the Institute of Clinical Sciences at Gothenburg University in Sweden, which I may have just mispronounced, and if so, I apologize. He serves as university lecturer in surgery with particular focus on disaster medicine, mass casualty management, and trauma. I'd like to ask each presenter, if possible, to spend about 8 minutes on their presentation. Following that, we'll do a short panel discussion and then open for audience questions in the Q&A function on the Zoom. You will hear me audibly break in just to let panelists know sort of time as we go along. Everybody's already agreed that's not disrespectful. So without further ado, Professor Theresa Betancourt, I'll turn it over to you.
Thank you very much, Tiziana, and thanks everyone for being here today to discuss this very important topic. Can you see my slides? So I'm going to talk about the mental health of children and families affected by armed conflict and sort of move through some of our research on this topic and how we've been able to move from longitudinal and now intergenerational research on the impact to the question of scaling up, because we're talking about very large numbers, and moving more into implementation science on how to address the mental health response. So I direct a research program on children in adversity, as you've heard, and really we're trying to understand where we can have leverage in influencing more resilient life outcomes in children who are affected by a range of adversities, with the focus on strengths and not just deficits. And really to help contribute to bridging the gap between what we know about the impact of adversity on mental health and child development and what's done on the ground, especially in low resource settings. I won't perseverate on the numbers, except to emphasize that we were already facing the largest humanitarian crisis since World War II prior to the Ukraine outbreak. And now estimates from UNICEF are that the number of children living in conflict zones has risen by 74% in the last decade. In Ukraine alone, we've seen 4.3 million children both internally displaced and displaced as refugees. So what we see in modern warfare are wars of destabilization, as you've heard from Dean Galea, wars that involve attacks on the fabric of day-to-day life, schools, hospitals, clinics, the places where children grow and develop. So this has implications for their immediate survival, but also the course that they're placed upon in their lives in terms of access to education and other life opportunities. So if we're talking about 20% of the global child population, this is not a side issue. This is a central public health issue. And you see here some of the hot spots. When you talk about fragile and post-conflict settings, it's even more numbers that we're referring to when we talk about child development and mental health. And certainly for any one child's mental health, we have to think developmentally, ecologically, individual factors, age, gender, temperament, but also the family, who's available to the child, what is the nature of caregiver relationships, caregiver mental health, and then the broader community, networks, peer networks, how those are affected, access to other people in the lives of the child, as well as religious figures, and a sense of opportunity and hope for the future, as well as the societal, historical, and the cultural context and meaning making given to the conflict itself. So when we talk about mental health in war-affected children, there are now a range of studies documenting very high rates of traumatic stress reactions, depression, anxiety, risky behaviors. Here are some of the statistics on PTSD, both in war-affected children, also children involved in armed conflict as child soldiers, which is a topic I've worked on. But we don't have enough research still that examines the longitudinal pattern of mental health adjustment, what this means over the life course, and also what we should do in the post-conflict environment in terms of protective factors, how we can leverage those in our intervention models, and especially interventions that begin to think about intergenerational trauma and family-based prevention. It used to be when I would give this talk, we didn't have enough literature on what works, but actually now we have a range of systematic reviews showing that evidence-based mental health interventions can make an impact for children and families affected by armed conflict. But we're not doing enough to really think about how do we get to scale given the numbers involved? How do we strengthen social services and mental health systems and expand the reach of evidence-based mental health interventions? So we've been working on these topics now in the context of armed conflict. I've worked on the Chechen conflict, the Ethiopia-Eritrea border, northern Uganda. I'll focus in on Sierra Leone a bit. And we're also working on family-based prevention, which started first in Rwanda, post-genocide Rwanda, on HIV and AIDS-affected families. And now we're doing this work with Somali, Bantu, and Bhutanese refugees here in the United States and expanding this to Afghan families. If you are interested in adversity in children, unfortunately, Sierra Leone offers far too many opportunities. This is a country that ranks 182 out of 187 countries on the UN Human Development Index. We had an 11-year civil war, 1991 to 2002, which really laid bare the health system, allowing the vestiges of the Ebola outbreak in 2014, 2016. And after the war, we started an intergenerational study, first following the lives of 529 young people. They were 10 to 17 at the end of the conflict. We've had assessments in 2002, 2004, 2008, and 2016. And in 2016, we added the intimate partners of this sample, many of them former child soldiers, but also their biological children. And so I won't be able to go into details except to say one of the main contributions of the study is certainly we see specificity of certain war-related traumas associated with certain mental health outcomes. But all of that is made much worse by a now degraded post-conflict environment. And children are much worse off if they come back to stigma, poor access to education, multiple daily hardships, food insecurity, housing insecurity, and low sources of social support and guidance. And we started to think about life opportunities, and it was really these symptoms and impairments that would get in the way of young people taking up things like accelerated education. And this is a photo of Educate. It's a free educational program for children affected by armed conflict, but it does expect the following fees to be paid: excellent attendance, excellent behavior, and excellent effort. And for many war-affected youth, they can't pay those basic fees. And so this brought us to think about intervention, drawing from the longitudinal study. How could we adapt evidence-based components that have been used in other interventions with violence-exposed youth and test them out in Sierra Leone to see if we could have impact? And so this is a group intervention model meant to be delivered through task sharing, non-specialists being trained by the very few specialists in the country. We did see in a randomized controlled trial published a few years ago significant improvements in youth who got the readiness intervention on emotion regulation, interpersonal skills, functioning day-to-day, and social support But even more exciting, teachers who didn't know who had received the intervention and who hadn't reported better classroom behavior, better attendance. And we actually saw that those who received the intervention were 6 times more likely to persist in their schooling. So this brought us to think about then entrepreneurship and employment programs. And we partnered with the German development agency GIZ in an implementation science hub called Youth Forward, funded by the National Institute of Mental Health. And we find in screening youth applying to employment programs in post-conflict Sierra Leone, 40% meeting criteria for emotion dysregulation and functional impairment. And so this was a hybrid type 2 trial. We were studying effectiveness, but also this new delivery platform of reaching youth, war-affected youth, through employment programs and the barriers and facilitators to doing this, and using collaborative team approaches as a strategy for integration. I also wanted to talk a little bit about family-based prevention. We've been writing about the intergenerational effect of war. We see in our sample in Sierra Leone over 400 children born into that cohort, and associations between parental emotion dysregulation and things like positive parenting being less possible when you have a lot of that sort of a difficulty, or a parent's dysregulation associated with externalizing problems in their children. And so we probably—
Thank you.
We've done our best work on family-based prevention in Rwanda, where we've now worked with the government there to scale up family home visiting, which focuses on father engagement and violence reduction, as well as promoting early childhood development into their social protection or poverty reduction strategy. In a huge cluster randomized trial of over 1,000 families, not only did we see an improvement in stimulation, nutrition, and health seeking, but also a reduction in violence against children and against intimate partners, and improvements in mental health in both mothers and fathers who received home visiting. We're now testing how do we integrate this into the government workforce of non-specialists who work in social protection and child protection. This is an initiative called the Play Collaborative. It involves cross-site learning to scale the intervention to 10,000 households. To do this, we're using digital tools for quality improvement and to support home visitors. We're adapting similar digital tools now for home visiting back in Sierra Leone. We've been able now with Dr. Alicia DeRosiers to adapt this to an mHealth intervention in Sierra Leone. And finally, I'll just mention the work we're doing on refugees here in the United States, where because of workforce issues and culture and language ability, we have found that non-specialists who are refugees themselves can do excellent work in home visiting, in family-based prevention done by refugees who are resettling new refugees. We've tested this with Somali, Bantu, and Bhutanese and are now moving to Afghans. We would hope we could even do models like this with Ukrainian displaced populations. So in summary, I hope I've been able to emphasize that trauma has an intergenerational effect, that we have to think developmentally and ecologically. And really as a field, it's time to move towards these questions of how do we reach the numbers? How do we scale out, scale up, and ensure quality as we spread these practices and strengthen systems around the world? And we need innovation. And sometimes out of low resource settings comes the most amazing innovation, integrating into employment programs, social protection programs, education programs, evidence-based practices, working on data to show about the importance of return on investment and work with major development actors. So I just want to put in a shameless plug that we're hiring, given all of this new work, and thank you for having me here today.
Love the shameless plug at the end. Thank you very much. I'm going to immediately turn it over to Dr. Ekzayez. Kareem.
Thank you very much, Professor. Let me share my slides. So, you know, I know that most people tend to maybe remember stories, and that's why I will try to put the facts and the research that we've been doing into real life stories. So in 2012, I was doing my training program in neurosurgery in the city of Aleppo, northern Syria. And when the conflict started, I was midway through my training program. But in the governmental hospital where I was doing my training program, we were not allowed to treat protesters after the revolution erupted in Syria. So we had to treat patients at home, but also at home, we were being pushed by security agencies not to do so. And many of my colleagues were detained and some of them were tortured to death. So that's why many health workers, many physicians, including myself, had no other option but to leave to the other the other half of the city. And Aleppo city, with a 4 million population, was divided into areas controlled by the government and areas controlled by oppositions. In the areas controlled by oppositions, people did not have access to basic health care. And we had to establish some basic field hospitals. In these field hospitals, we had to treat protesters after each demonstration, and those hospitals will look like something like this after each demonstration. So, but then because of the various attacks on healthcare, we were really limited into what we can offer as local practitioners. So I joined Save the Children and I led their health response in Syria, building primary healthcare and also vaccination programs. But also I was looking at issues related to how to strengthen the health system in Syria, including health information, supplies, governance, and other issues. And I decided to put this into an academic practice, and I joined London School 6 years ago. But then even academia was not enough, so I decided to do more policy-oriented research. So I joined Chatham House 5 years ago, and since 4 years I've been with King's College leading some of their projects on health system strengthening in conflict settings. So what happened in Syria, just trying to provide a case study of a local picture. So in 2011, after demonstrations started, people were seeking freedom. They were faced with violence from the Syrian regime. And this divided the country into different areas of control after different regional and international powers were involved in the conflict. The red areas are the regime-controlled areas where one health system is led by the government, the Syrian government. In the green areas of opposition control, there is completely different health system, which is led by the Syrian Health Directorate. In the yellow areas, which are Kurdish majority, led by the self-administration with another health system, and also the Turkish Ministry of Health is involved in providing health services in the areas where the Turkish army operates. So, but what's the impact of this crisis? More than 13 million people are in severe needs, and also people were being displaced, fled their homes, some of them multiple times until they reached their final destinations, either inside the country or outside the country. As a result, some of the times areas were besieged. And we are seeing this tactic, unfortunately, again happening in Ukraine. In this area, which was in rural Damascus, in Ghouta, eastern Ghouta, more than 70 people died out of starving in 2014. And the WFP program was only 5 kilometers away in Damascus, but they were not allowed to provide life-saving services to those people. And that's why forced displacement sometimes were enforced by the Syrian regime and their allies, forcing a lot of people to move out of their homes and to move to other areas in the country. And we ended up with having huge, not only displacement, not only refugees, but also displacement, so the internal displacement. So inside Syria, there's more than 6 million internal displaced persons, and globally we have about 7 million refugees. So half of the country population were displaced either internally or externally. Health system was severely affected. This hospital, I used to get some practices in this hospital 15 years ago. It's called Al-Kindi Hospital, and this used to be the 4th biggest hospital in the Middle East for cancer treatment. But this was completely damaged, similar to more than 50% of health infrastructure in the opposition-controlled areas. And more than 27% of the Syrian population, they live in areas where they do not have access to a health workforce. The rate of physicians per 1,000 population is almost 1 doctor for each 8,000 population in opposition-controlled areas. And to respond to attacks on healthcare, health workforce and local doctors, they decided to build hospitals inside mountains. And this is, you see here, an entrance for a hospital that was built inside a mountain. But even this hospital was targeted many times. The doctor who established this hospital, Dr. Hassan Al-Araj, was targeted by a targeted missile targeting his car when he was just stepping away from this hospital. The Physicians for Human Rights, they documented more than 600 attacks on health facilities in Syria. And most of these attacks were happening on opposition-controlled areas because most of them are being done by airstrikes, and only one party to the conflict, they have this air power, which is the Syrian regime and their allies, the Russian government. And unfortunately, we are seeing this happening again in Ukraine. More than 76 attacks were documented by the WHO in Ukraine since the start of the Russian campaign. But how to respond to this? I think we should not allow this to happen. And the first step is to document how to report these attacks. The WHO, they launched a system called the SSA, which is System for Surveillance for Attacks, in 2018. But in my paper with the Chatham House, I discuss some lessons to be learned from the Syrian context on how to report these attacks, learning from the local innovative approach that were implemented in Syria, but ensuring local engagement and participation. And also, I argue that some of these attacks in the Syrian context were part of a military tactique. So it's not a collateral damage. I argue that there were 5-step military tactique that started with besiegement and then targeting civilian infrastructure, but then focusing on health care, and then fourthly, enforcing forced displacement deals. And fifthly, if all failed, the use of chemical weapon could be a last resort. By how the health indicators were affected, the top killer after the conflict is for sure conflict terror. If we look at the global burden for disease, for example, in Syria, after the NCDs were dominating the burden of diseases, after the conflict now we have a triple burden of non-communicable, communicable, and man-made or conflict and terror.
About 1 minute left.
Okay, so all health indicators were affected. Mental health were affected severely. You can see the red line is Syria, so it dropped compared to all other regions in the world. In this study, I linked a conflict incidents database of more than 12,000 incidents to number of consultations, and we can see a positive correlation between a negative correlation between conflict incidents and the utilization of health services. And strangely enough, the conflict incidents were correlated with double deliveries and even triple C-sections. So just as we don't have time, so briefly, how we can use this innovation to document the best practices. We started recently a research project in King's College called Research for Health System Strengthening in North Syria. For more than 4 years, we've been doing an annual conference for health research in the Syrian conflict, engaging with all partners, and we introduced multidisciplinary equal partnerships between academia, policy, and humanitarian actors. So in this project, which is supported by the National Institute for Health Research, we do several embedded operational research every year with the humanitarian practitioners, and we aim to build the capacity of local practitioners, including 3 levels: individual, institutional, and organizational level. So we hope with this research that we will pave the way for more evidence-based and evidence-informed health policies to rebuild the health system in the country, and also to learn from what happened in Syria to other complex settings. Thank you.
Thank you, Karim. Professor Larissa Fast, I'll immediately turn it over to you.
Great, thank you so much. I'm very pleased to be part of this important panel. I believe someone is going to put up my slides. So I'm going to focus my comments on a specific set of health consequences that Karim has actually very helpfully introduced to you. And more specifically on the attacks on healthcare and the impact of violence against healthcare in situations of war and armed conflict. So next slide. These attacks are next. Yep, thanks. These attacks are unfortunately far too many and documented in media reports, with recent attention to the bombing of the maternity hospital in Mariupol in early March. But this is just the latest such attack. There are many more instances of bombing of health facilities, whether by Russian artillery in Ukraine and Syria, by Saudi Arabia and allies in Yemen, or even the US military in Kunduz, Afghanistan. Far too often, those who perpetrate these attacks go unpunished, and the civilians pay the price. So WHO has recently highlighted some of the impacts of the war on health for Ukrainians, highlighting that close to 1,000 health facilities are close to conflict lines or are in areas of changed areas of control. So as a result, they have limited or no access to medicines, to facilities and health professionals. And that means that the treatment of chronic conditions has almost entirely stopped. Next slide, please. So artillery attacks and bombing resulting in the destruction of hospitals is only one such example. So a report by my colleagues at Insecurity Insight from late last week documents these different types of attacks in Ukraine over the past month. They are relentless, these attacks. So I'm going to use my time to highlight two key issues. The first is the importance of understanding definitions and context. And the second, how to differentiate the impact of war for health more generally from the specific impact of attacks on healthcare in war. Next slide. So in this presentation, I'm drawing on my work with colleagues at the Humanitarian and Conflict Response Institute, where I work, the University of Geneva, Johns Hopkins University, Berkeley, together with Insecurity Insight and Chatham House. We are all part of what we call the RIA Consortium, which is researching the impact of attacks on healthcare. Our purpose is twofold, really, to collect and collate data on what we call the instances of attacks, the attacks on health themselves, but also to develop methods and to document evidence of the impact of these attacks. So there's been a lot of attention to the attacks themselves and less on the impact on the civilian population. So we're doing case studies in Afghanistan, in Nepal, in the Central African Republic, Colombia, and a historical case study of World War II in an attempt to use a variety of disciplinary insights to gain a better understanding of the impact of such attacks. We're still in the midst of data collection and analysis, so I'm going to only highlight some preliminary findings from our case in Afghanistan, where we have interviewed health workers combined with secondary data about attacks to focus on the impact on health workers and facilities. Next slide, please. So in Afghanistan, from our research, we know that certain types of attacks are not necessarily reported. And you can see that illustrated in the sort of the word cloud of different types of attacks from these two sources of data. We also know that there are significant impacts on health workers' mental and physical health, their private lives, and also their practice of medicine. As Karim documented in Syria, for example, health workers have moved literally underground in order to provide care. We also know there's a lack of protection and support measures. But as you can also see from the slides, different data sources have identified different types of attacks. So the way we define attacks also determines what we know about them. In other words, definitions matter. So bombing is a feature of attacks on healthcare in Ukraine, but in Afghanistan, forced closures occur a lot with a dramatic impact on civilians. During the Ebola crisis in West Africa and in the Democratic Republic of Congo, attacks took the form of arson of facilities, and so the burning down of health facilities, and also attacks on health workers who were attempting to provide care. This was also a feature of COVID or of COVID-related attacks on healthcare that occurred around the world, not just in conflict zones. So this highlights the importance of definition and requires a knowledge of the conflict dynamics, which also impact on the types of attacks that we see in different places. Next slide. So this map, for which RIA supports the data collection, highlights attacks on health over the past 5 years since 2016. You can see from this hotspots and numbers for these attacks, many of which are countries experiencing war or armed conflict. But for me, it raises the question, how do we differentiate the impact of war on health from the specific impact of attacks on healthcare in war contexts? So how do we distinguish the effects of the maternity hospital bombing from the effects of the war of attrition in Mariupol? This requires methodological innovation and rigor. We can think about impact in many different ways at many different levels. So just to name a few, we can think about the impacts on health workers, their practice of medicine, their mental and their physical health, the effects of these attacks on their family members. We can think about the effects on health facilities, the number of patients who are able to get treatment when hospitals and facilities lose health workers because they're killed, they're injured, or they're simply unable to get to work because of the violence that surrounds them. The supply chains that might be disrupted and health facilities then run out of medicine and supplies. We can also think about access to care, patients' ability to actually reach healthcare facilities, or even their desire to go and seek healthcare if they think these facilities are being targeted by conflict actors or being targeted in situations like Ebola. We can also think about the utilization of health services. So to document and assess these impacts, we need qualitative and quantitative data. Next slide. So unfortunately, we still don't necessarily have really good answers to many of these questions. We're beginning to understand how to document impact and the types of data and the detail of data required to answer these difficult questions. We're beginning to develop and identify methodologies to better understand what data we have about health outcomes and the quality and limitations of these data and how it inhibits or enables our understanding. We're working with national and regional health actors to identify and use secondary data sources about health behaviors and health outcomes. We won't always have the luxury or ability to collect primary data, so it's important to also look at existing data sources to see what is and is not possible in documenting impact. So these are a few of our research products, both policy related and academic research that we've published so far. Thank you for listening, and I look forward to further discussion. Thanks.
Larissa, thank you so much. Okay, so lastly, I will turn to Dr. Amir Khorram-Manesh.
Thank you so much. I would like to thank the meeting organizers for inviting me to such an important event. The topic today is the health consequences of war. Although no fight is good, it is logical to ask what kind of wars we prefer. What we experienced before the Vietnam War mainly was interstate wars. Next slide, please. Using conventional warfare. These wars were traditional since military service members and their resources were targeted. Yet, there was something extra for many to do something for the interests of their nations. Wars are not good, but at least conventional wars follow international rules and regulations, such as international humanitarian law and the Geneva Convention. They were often declared in good time to give the opponent time to evacuate civilians, since the objectives of the war were to attack and destroy military targets. They had global economic impacts. The social cultural influences were not primary. They did not use criminal gangs, although the criminality rate could be higher for other reasons. There was limited but reliable information and trust in the government. We had fewer cyber attacks, and other vital necessities of life could be intact for civilians, such as energy and water sources. The medical consequences were divided into those within the battlefield, which were known and could be estimated, and those out of the battlefield following the natural course of disaster and diseases and their etiology. From the turn of century, we faced many new wars. Simultaneously, there has been a transition from interstate wars to guerrilla wars, terrorism, and nowadays hybrid wars, which are multi-domain warfare targeting several opponents' weak points, including its civilian population. Since technological developments and other military costs did not allow all countries, including superpowers, to increase and update their military arsenals and capacity, several nations started hybrid war instead of modernizing their costly military power. Here, they try to save their soldiers using proxy fighters. Civilian and military goals are both targeted. The war does not follow the traditional rules and does not allow observation by international humanitarian organizations such as International Committee of Red Cross. The aim justifies the approach and often targets weakening the government in the invaded country, using criminal gangs to do internal jobs, spreading misleading information, and targeting socio-cultural life to create insecurity, chaos, riots, and mistrust in the government-population relationship. They are attacking infrastructure, hospitals, energy, water sources, banks, and other civilian economic sources to increase people's confusion, frustration, and desire to change their government, substituting it with a new proxy. Here, the medical consequences cannot be estimated, since it is not about the war game and its panorama of various injuries, but also trauma and all health issues that appear due to the disruption in the infrastructure and the function of regular healthcare facilities to receive ordinary patients in the affected infrastructure. The impact can be, next please, next slide. The impact can be the release of chemicals, poisoning, nuclear incidents, radiological events, fires, explosions, transportation accidents, structural collapse, and everything else in a chaotic situation. The specific medical condition may vary, but mainly are listed there as poisoning, suffocation, traumatic injury, burns, radiation, illnesses, drawing, and disrupted road, water supply, and sewage disposal lead to public health consequences. Next slide, please. Therefore, additional public health consequences should also be considered due to the loss of public safety, hygiene, clean water, electricity, shelter, sanitation, mass migration, all of which impact the overwhelmed healthcare services that should also be concerned about worsening existing chronic diseases, psychological illnesses, food shortage, and worsening of endemic diseases. My friend, these are not good news, and there is no definitive solution for such issues I mentioned. The only solution is to stop wars. In a new world, next slide, please. In a new world where no people have reasons to not to hear, see, or speak to each other. They produce dangerous tools with no respect for humanity and humanitarian law. The use of lawfare, that is the use of law as a weapon of war, or misuse of the law, such as defiling and bastardizing the established definition and work of peacekeeping to misrepresent their true objective is an illustration of what is going to happen to our democracy and values if these intrusions are allowed to occur and no reactions and no countermeasures are presented. Thank you so much.
Thank you. I appreciate it. And I'm going to move us into our panel discussion now. So if I could bring all of our panelists back up, and I'm going to encourage you, if you don't mind, to stay unmuted for this next part, because I really hope that there will be opportunity for you to interact with each other as opposed to just answering my questions. It's a little bit overwhelming to take in the full scope of not only the immediate damage, but the future damage and long-term implications of what you're laying out, both in the health implications of war and what you've learned about the way warfare is unfolding and what it takes to be responsive to the physical, mental health, and infrastructure needs in a long-term way. So it's a lot to take in. There are a number of questions I have, but the first thing I think I'd like to ask is there anything that you are witnessing in this conflict, in this moment in Ukraine, that is unprecedented or fundamentally unexpected or different than what you have come across in your research to now? Do you understand my question? And is there any of the four panelists who want to take that on?
I can say something about parent-child attachments. You know, we did have a period in time, such as the evacuations from World War II, where there was this belief that if you could just get the children out of danger, that's what mattered. And I think as a field, we've come far to understand that going through frightening events that are rife with toxic stress exposures and trauma for children, that those attachment relationships are fundamental. And I guess I'm encouraged by seeing the degree to which there are caregivers and children not separated in the numbers we'd normally see in sub-Saharan Africa and other conflicts where I've worked. And I think that bodes well for working with families and promoting mental health, but still the degree of trauma and the children who are separated or abandoned or left behind are, you know, remaining of tremendous concern. But I do think as a field, we're starting to understand a little bit more about the supports needed in terms of promoting child and family mental health.
Thank you. Amir, it looked like you were going to add as well.
Well, not really add, because I've been actually to Ukraine 2015-16, and the reason for that was we had a special training session for Ukrainian EMS for 2 years, and I'm very much aware of the situation. I'm not surprised by any action taken in Ukraine at the moment, because this is exactly what is supposed to happen in a hybrid war. The thing that surprised me is that the world has reacted too late, because this has been an ongoing situation at least since 2014, and suddenly everything is loud and clear now. So that's the only surprising moment from my side.
Karim and Larissa, picking up on the point that Amir just made about sort of the features, for lack of better word, or characteristics of a hybrid war. There were themes running through both of what you talked about that felt like, to a layperson, the cruelty is the point, that there is a level of full-on assault to not only well-being and safety now, but to the ability to provide for well-being and safety in an ongoing basis that is almost hard for a layperson to get one's head around. And I wonder if you could pick up that thread and reflect on it a little bit. Karim, you happen to nod first, so I'll go to you first, and then Larissa, I'll go to you.
Sure. I think looking at concurrent conflicts in the last 20 years, I think there are some similarities there. Yes, in terms of brutality, but also in terms of chronicity, and also being urbanized, more urbanized. And I think the repeated breaches of international laws are, being very similar in Syria, Yemen, Libya, and now in Ukraine. And I think the problem here that the international community is allowing this to happen, which means that unfortunately some of these practices practices are becoming the new norms. For example, attacks on healthcare was something that was strongly condemned, but at the same time, we are seeing this increasing. Similarly, for example, the use of chemical weapon was, I think repeatedly was used as, a new, a part of the tools of warfare. So from the one hand, the nature of concurrent conflicts are being different now. I think there should be something to be done about this. But also from the other hand, I think the traditional humanitarian system is not coping with these changes in the types and typology of conflict. I think the traditional humanitarian system needs to be changed. And some of the lessons that we learned from, for example, our experience in Syria, is we need to have more meaningful engagement with the local actors. We hear about the word localization since the Humanitarian Summit in Istanbul in 2016, but I do not think that we do have an operational framework on how to embed localization into the humanitarian system. So we have more inclusive, more diverse, and also more powerful and effective humanitarian systems that not only look at humanitarian life-saving interventions, but also build the local capacity to think about peace building and to think about development. And that's what we hope that the triple nexus, humanitarian development and peace building, would bring. But again, I do not think the humanitarian system is ready to operationalize the triple nexus yet.
So Larissa, I'm going to turn to you, and then I'd like the audience to know that from there, I will begin to turn to the questions that you're posting in the Q&A section of the Zoom. Larissa, go ahead.
Yeah, so I agree with some of the things that Karim just highlighted. I guess the sort of taking your two questions, I would just highlight two things. I think one is the information war that is happening, and how information is and health information can be weaponized, and how attacks on health feature in that. I think that is something that began in many ways, not even began, but we began to see it around attacks on health in the pandemic and in the Ebola crisis, where misinformation became the basis or the justification for attacks on health workers and health facilities. And I think that kind of thing is continuing in Ukraine. And then I guess the other thing I would highlight then is the use of data more generally, and how that can also be both it's a necessity in terms of providing healthcare and support to actually collect information about symptoms and such, but how that information, if not well protected, can also then lead to new vulnerabilities of those affected by war and conflict. And so that the importance of data, I think, would be another thing that I would highlight.
Thank you, Larissa. So I'm going to begin picking up a few of the questions from the Q&A. We certainly will not get to all of them, and I appreciate the audience's deep engagement. Theresa, maybe I'll direct this first one that I'm going to ask to you. It's from guest Elizabeth Ferreira, and it says, what role, if any, would mental health first aid play in this lack of resources for mental health help for displaced children and their social support?
Sure. No, thanks for that good question. So psychological first aid is a practice that's increasingly used and has been very helpful, as a first line of defense in terms of providing information, social support, basic coping skills. And this is sort of replaced what used to be debriefing, which was more trauma focused when people didn't have an ongoing relationship. There were actually some adverse effects from those sorts of practices, but helping people with the basics and to connect them to information is very helpful for stabilizing, but it's not all that we should be doing, right? You have to then make sure that people get those referrals, that children get back into emergency education, that parents are getting the supports they need to take care of their own mental health, and that we're thinking about permanency and predictability in the lives of displaced populations over the long haul.
Thanks, Theresa. Amir, I think I'll start with you on this next question from Griffin Barris. Are there any potential updates to IHL, such as a 5th additional protocol of the Geneva Conventions, which could better emphasize and protect public health's role in the war? Or is the only real solution for unlawful actors in the international system to shift their perception of the current IHL regime?
I think the latter is correct. I mean, that's exactly what they do. They mislead people with their own interpretation of everything. And if you look at the Ukraine situation, one of the issue was sending peacekeeping forces and pretending that they are going to do something positive. The Russian history shows that their peacekeeping activity has not been in the favor of the international community, but in their own favor. So I think whatever the updates of IHL would be, it doesn't matter. We must have a more powerful United Nations. We need to have a more powerful group activity against this kind of dictatorship.
Thank you. Larissa, I think I'll direct this next one to you. This is from Helen Lindsay. In the past, we have seen prolonged health impacts of conflicts such as spread of Acinetobacter, I actually can't pronounce that, I apologize, Baumani, and toxins in water sources after the Lebanese civil war. With ongoing conflicts, what can we do to limit future health consequences or be better prepared to address them after conflict ceases? And I apologize for stumbling over the technical term there.
Yeah, that's a tough one. I think part of it is, I'll go back to something I said earlier, like the more we know about the dynamics, the patterns of attacks on health, of the ways that civilians are affected, both in terms of the immediate, but as the broader and longer term effects. So the more research that we do on these kinds of effects, the more that we can also then work to translate some of that information into better protection, into more effective ways of responding. But here I'll also highlight something that was said, that Karim actually mentioned earlier, about the importance of local actors and understanding of both conflict dynamics, but also responses and what is appropriate and effective in a given context, because that will differ from place to place. So I think while there's knowledge that we can gain that is more sort of global, really understanding and drilling down to those specifics is also hugely important.
Karim, I'll direct this next one to you. It's from an anonymous attendee, and it says, question about race of victims of war. We've seen shocking, though perhaps sadly expected, differential treatment of refugees by race. How can this be addressed going forward? More critically, does it mean the Western white world's assistance will now go mostly to the European refugees, and those in Africa and the Middle East will be in even more trouble? How might we prepare for such an unfortunate outcome?
As we know, the humanitarian principles clearly define few principles for any humanitarian assistance, including health one, including humanity, and impartiality. So hopefully, humanitarian assistance should be directed without looking to, without putting into consideration any issues related to race or religion. But I do agree that unfortunately we are seeing this increasing, what I call weaponization of healthcare, and this is happening because I think we need to understand that there are new unusual actors in health systems around the world. Even non-state armed actors could be providers of healthcare. Look, for example, what happens in Lebanon, and Hezbollah is a health provider in southern Lebanon. And sometimes, unfortunately, they use health to either deprive populations or to reward populations. And I think this is happening elsewhere, but hopefully, I think in the Western world, we need to reiterate humanitarian principles. We need to ensure that humanitarian health assistance is delivered without, differentiations, without discriminations. But I do agree that unfortunately, when the impact of those refugees would be greater in Western nations, then the response will be greater. And I think this is, a reality in the world we live in, and hopefully we can work together to address this by highlighting, the impact of these discriminations or the impact of these inequalities.
We have about 3 minutes left. So before I pick up any additional questions, one thing that I do want to do is open it to the panelists. I directed the questions to specific panelists, but if there's anything that you'd like to add based on what you've heard the other panelists say, now would be a great time to get those thoughts from you. Do any of you have things you'd like to add on the questions and answers we've already done?
As someone who's worked in post-conflict Sierra Leone, now 20 years post-conflict, I would just say you can't wait to think about building back and strengthening systems. You have to be in the emergency response as you address workforce shortages, as you address strengthening of management and training, thinking about how that can now lead into something that's more sustainable in terms of building systems, because they're going to be needed post-conflict. And I think as a field, we let this gap happen where there's a humanitarian response and then we wait for the development community to pick up the paces later. And we need to stop operating in that manner.
Thank you. Others?
Maybe just building on this, and I think Theresa mentioned previously about innovations, because sometimes we tend to think about humanitarian crises or conflict settings as places where atrocities happens and sufferings, but there are places where innovations do happen, and we need to learn from these. So some of the quick lessons, the importance of, for example, bottom-up approach rather than top-down approach in humanitarian settings and also in policies, the importance of capacity strengthening, because we need to understand first what available capacities are there. And I think some of the problems with the international humanitarian system that they tend to deal with humanitarian crises in a similar manner without really investing in available resources. So capacity strengthening, and also having a vision to think about sustainability, about how to bridge the gap between humanitarian and development, linking those to the point that I mentioned earlier about the need to operationalize the triple nexus.
So Dean, Larissa, did you have one more comment? We get a minute before I'm supposed to turn it over, so go ahead.
Very, very quickly. I would just say, I think there's also a role for the public in sort of getting, putting pressure on lawmakers to ensure that IHL is respected, to, actually operationalize the enforcement of existing humanitarian law, which does actually protect healthcare and health workers in situations of armed conflict. Thanks.
Thank you. Dean Galea, I will turn it back over to you.
Well, thank you very much, Tiziana, and thank you to all our panelists, and thank you to the audience. These were some really outstanding audience questions. It's really terrific to see audience engagement like this. The war is such a tragedy, and I felt over the decades often that we do not think enough about war, because war fundamentally, the consequences of war are all about health. They should be central to our thinking. All of us who are engaged in health, population health science, the practice of public health, and this the war in Ukraine just brought this so visibly, so tangibly in front of our attention, even though we all realize that there are many other wars, which some of you spoke very well about, like wars in Syria, Sierra Leone, Yemen, that have been going on for decades. So, as I said at the beginning, it is impossible to find a silver lining to something as horrible as war, but surely it should be a reminder to us all that we need to be having this conversation to elevate the visibility of the health consequence of war to the end of creating a world where war is unacceptable, to the end of creating a world where we will look back on a time when there were wars and think that is a time that has passed. What we've learned in the past couple of months is that we are not there yet, but I very much hope that in coming decades, the world will get there. And I think it's conversations like this that keep the consequences of war in the forefront of our mind that can get us there. So I want to say thank you to our panelists for the excellent work you all doing. Thank you to Tiziana for moderating an outstanding conversation. And thank you to all our audience for being a part of this and for everything you all do. Everybody take good care. Have a good afternoon. Have a good evening. Take care.